Send in your questions to questions@allhealthtv.com or AllHealthGo on Facebook or YouTube, or visit the Ask the Doc page on our website, allhealthtv.com.
Welcome to Ask the Doc, the show where we encourage our viewers to send in their health-related questions. I'm Dr. Georgiy Brusovanik, a minimally invasive spine surgeon. Let's start things off with a question from our Facebook page. This is from Eldon. Eldon asks, "Hey doc, my grams called from Florida to tell me that she has a fracture in her spine. Unfortunately, the call got lost because they were experiencing a storm down there, so I don't know what happened. What are the common causes of spinal fractures in elderly individuals?" Eldon, I'm sorry to hear that about your grandmother, and I'll give you my thoughts. I'll try to get back. I'll try to get her back on the phone if I were you. In general, spinal fractures are very common in the elderly, and the reason is because almost universally, as we cross a certain threshold, we develop weakening of our bones. Studies show that we accumulate calcium in our bones really only throughout our childhood, and starting from as early as your 20s, your bones get weaker and weaker and weaker. So osteoporosis is an inevitability, and with enough weakening of the bone, the spinal vertebra just sort of start to collapse one after another after another. Now, that's the most common fracture, and the good news is that unlike its name implies, spinal fracture, something scary and ominous, these fractures of fragility, as they are frequently called, actually are usually not dangerous, and most patients who have them don't end up having surgery either. Now, what we can do these days in the realm of minimally invasive is put a little baby needle through the skin, through the bone, right into the fracture site. Once the needle is in place, we inflate a balloon that gets the fracture out of its compression or kyphosis, and then we inject cement that's called kyphoplasty. The cement will keep the bone in its proper position and will solidify a soft, weakened fracture site. But I'll tell you, the most important message isn't what we can accomplish with minimally invasive. It's that osteoporosis deserves medical management. So the American Academy has made it very clear to guys like me, to orthopedic surgeons, that once you see a patient with a compression fracture, we have to find out whether indeed they have osteoporosis and then treat the osteoporosis with various new medications. I hope your grandma gets back to normal soon, Eldon. Our next question comes to us from Feivel, who reached out to us on our very own website, allhealthtv.com. Feivel asks, "Shalom, Dr. Brusovanik. My Bubby hurt her back recently, and after hearing about the last caller, I'm wondering if she has a spinal fracture as well. I've got a twofer for you. What are the symptoms of a spinal fracture in the elderly, and how are they diagnosed?" Feivel, shalom, back at ya. Thanks for the twofer. I'd like to suggest taking your Bobby to the doctor sooner than later, because really, in general, when there's a new onset of back pain in anyone over 65, we have to think about a compression fracture. And especially if it's in the mid-back, you don't need to have any significant trauma to have these kinds of fractures. So if grandma starts to have new back pain, she deserves x-rays at the minimum. That means a visit to the doc and possibly an MRI. Again, it's not a dangerous problem, but you definitely want to know whether there is a fracture, particularly because then you can stop the underlying metabolic process, specifically the osteoporosis. I hope this helps you, Feivel. And how is it diagnosed? Again, MRI, X-rays, or a CAT scan, all of the above really should show you if there is a new fracture. Rita reached out to us on our YouTube page, and her question for me is, "Dr. Brusovanik, can spinal cord stimulators cause migraines? I've had migraines my entire life. I even had an epidural during one of my deliveries, and it gave me a horrible migraine. I'm asking because I read recently that stimulators were implanted in the same area as epidurals. I'm having severe back pain now that's affecting my quality of life. but I'm not looking for migraines either. Wow, Rita, this is a very complicated question. I understand your concerns about migraines, but before I give you my thoughts, let's check out this video from Mayo Clinic.
Hey, Julie? Yeah. We're turning this on now, okay? Yeah. Let me know when you just start to feel it.
This is a big day for Julie Williams. Pain medicine specialist Dr. David Mock is implanting a device into her spine. The goal is to reduce chronic, debilitating pain.
I'd had a back surgery when I was 25 for a disc, and I had pain down my left leg at that time.
The pain went away until about a year ago.
It was down my left leg into my left foot, and it was, gosh, sometimes 9 out of 10, burning, mainly a burning pain.
Julie's pain got so bad it interfered with work as a physician's assistant. Medication only masked it. The pain was wrecking her quality of life.
So this is what a device might look like.
Dr. Mock says the spine stimulator emits electrical impulses.
Think of it as a pacemaker for the spine is probably the simplest way to look at that.
During the procedure, he and his team first place a temporary device at the level of the spinal cord where the nerves are that generate the pain. It gives off small electrical signals that mute what patients feel. Instead of pain, they feel a pleasant buzzing sensation in the affected area.
This is a really interesting video. And I gotta tell you, this is a bit controversial too. Spinal cord stimulator masks the pain. That's it. Period. Full stop. So if you have a problem that's fixable, like a degenerative disc, for example, because that's the most common scenario. Someone has a discectomy, the disc continues to degenerate, and then you go from having leg pain, which got better after the original operation, to now having pain when you sit, when you stand, difficulty walking, difficulty sleeping, pain going down the legs, car rides bother you, sitting at the restaurant bothers you, the most typical presentation of degenerative discs. These patients deserve a disc replacement, not to mask the pain. And look, spinal cord stimulator, it sounds so innovative, but it's still a spinal operation. In fact, since I implanted a lot of these over the years, you still have to open up the canal, incur the scarring, and you are not correcting the underlying cause. I believe that spinal cord stimulators are definitely important in our treatment of certain conditions, but really only for patients where correcting the underlying problem is just physically impossible. Now, that being said, migraines sometimes get treated by spinal cord stimulators, but migraines can also be caused by spinal cord stimulators. The bottom line is, what's a migraine? The classification of migraines is not very clear. And a lot of times patients will think they have migraines, but really what they have is pain in the back of the head, maybe the side of the head. Well, guess what? Most of the time that pain isn't coming from inside the head. It's coming from the occipital nerve that gets irritated by tight neck muscles. Hence, it's a neck problem that's causing these headaches. In fact, I'd say most of the patients who come to me with a neck problem will complain of headaches. And then when I fix the problem, the headaches go away. Rita, you need more of an opinion. You need to be evaluated. And it doesn't mean that you're going to live with migraines, but you should definitely have the situation with the spinal cord stimulator addressed, just to make sure at least that there isn't a problem with the underlying hardware. In case you missed it the first time, here's another opportunity to find out where to send in your questions.
Send in your questions to questions@allhealthtv.com or AllHealthGo on Facebook or YouTube, or visit the Ask the Doc page on our website, allhealthtv.com.
Welcome back. Manolo sent his question via our own website, allhealthtv.com. Let's check it out. Manolo's question is, ¿Qué pasa, Dr. B? I was grinding a rail with my boy, and he took a spill. His neck was killing him, so I took him to the hospital where he's been for the past couple of days. I heard something about spinal fracture. Does that mean he'll be paralyzed? Manolo, that sounds terrible. I understand your concern. I appreciate you reaching out. Just because you broke a bone in your spine does not, thankfully, mean that you'll be paralyzed. In fact, most spinal fractures aren't associated with paralysis. In fact, many spinal fractures don't need any treatment. Now, a C6 fracture from, as you said, grinding a rail. Sounds like a high energy fracture. So make sure that the opinion that your friend receives is an educated opinion. That being said, don't let anybody force you into spine surgery. And if you feel like you guys are getting pushed into doing that, please get a second opinion. I hope this answers your question. We've got another one. This one is from allhealthtv.com. You should really check out this site. It's chock full of great information. Camille asks, hello, Dr. Brusovanik. My mother, Magda, went to her primary care physician for back pain, and she thinks my mother has osteoporosis. Can you explain what osteoporosis is and how it contributes to back pain in the elderly? Camille, it sounds like your mother went to a real good doc, because considerations for osteoporosis essentially represent the best kind of prophylactic medicine. And we have a lot of claims for good quality prophylactic medicine, stem cells, a bunch of exciting pseudo-scientific words. Care for patients and making sure that they don't have osteoporosis actually prevents fractures, and it's not a gimmick. So kudos to your primary care doc. But in general, osteoporosis, to answer your question, it causes pain via fractures. Just having a weakened bone should not cause any pain. I'm sorry to hear that your mom is suffering from back pain, but unless she has another fracture, you gotta look for another underlying cause. And the elderly commonly have significant degenerative changes. So make sure you indicate to the doc where the pain goes down the thighs, down the legs. Sometimes mere presence of occasional nerve pain can really clue your doc into where the pain is coming from. I hope this answers your question. And I'd like to address your question further. We have a great video from Mayo Clinic. Please.
Osteoporosis is often called soft bones.
Osteoporosis is thinning of the bone to the point where the bones can break.
Dr. Bart Clark, a Mayo Clinic endocrinologist, says common breaks from thinning bones occur in the spine, wrist, shoulder, and hip.
Women in general past menopause, past the mid-50s, are at high risk for this because of the degree of bone loss they have due to the lack of estrogen.
The standard screening procedure for osteoporosis is a bone density test. Treatment is a combination of medication, adequate calcium and vitamin D intake, and physical activity.
So the perception is sometimes we can't fix it if it's a problem. It's just the opposite these days.
Dr. Clark says if you have osteoporosis, you need to be careful not to overexert your body, which can lead to fractures. But in general, simply walking for 30 minutes, 3 to 4 days a week is the right amount of physical activity. For the Mayo Clinic News Network, I'm Jason Howland.
Camille, I really hope that this video was helpful for you. And you should really feel optimistic about treatment for osteoporosis, especially prior to having any kind of fractures. Back in the day, the medications that were available only helped stop the resorption. And taking those medications for a long time actually increased certain risks, like weird pathological hip fractures known as subtrochanteric fractures, as well as other issues with areas where there's high bony metabolism, like, for example, in the jaw. Some of the newer medications actually help you build bone. They make it so that calcium gets further reabsorbed by bone, and they don't come with such ominous side effects as the older medications. So it may mean an occasional infusion, because some of these medications are done via an IV, but it's something that's really positive and effective. I hope your mom gets proper care, Camille. This next question is from our YouTube, from Vlad. Vlad asks, hi, Dr. Brusovanik, are there any advancements in surgical techniques for treating spinal fractures? I'm a man of a certain age, and since my back occasionally goes out, I figure I'd be proactive and ask. Vlad, thank you for sharing a question with us. Thank you for thinking proactively. So in terms of proactive, you gotta get an osteoporosis evaluation. That means getting what's called a DEXA test, or a bone density test. And then we have really good guidelines that a rheumatologist would be able to help you with in order to give you the right kind of pharmacological treatment. That's true prevention. Now, in terms of treatment, once the fracture actually occurs, I'm very happy to say that the world of minimally invasive has advanced spinal fracture care significantly. So earlier I mentioned kyphoplasty. That's for a compression fracture, a very common fracture, where we put a needle into the bone, inflate a balloon, jack up the bone, and then inject cement. That's magic for many patients. For patients who have what's called a burst fracture, where it's not only the front of the spine that's fractured, but also the back of the spine is fractured, these fractures are really unstable. That means that if you were to treat that patient without proper care, they may actually get worse, and they may actually hurt their spinal canal, nerves, or the spinal cord. That's a definition of unstable. And for these patients, we do what's called a percutaneous technique, where we use very, very small, little tiny incisions. We'll make 4 or 6 of them, depending on where the fracture is. And then through each incision, we place a percutaneous screw. We use robotics to place the screws or navigation, so the precision is in a 99.9% range. And that functions as an internal brace. About a year later, we usually remove the screws so as to avoid unnecessary stiffness. But by that point, the fracture has healed. Now, let's kick that up a notch. A fracture that has not only occurred close to the spinal cord, but is now pushing on the spinal cord and producing a neurological effect, a negative effect. Now, these patients deserve something more significant. You could still do it minimally invasive, though. Fixation can be done in a percutaneous manner, as I described earlier. And then we can sneak into the canal and remove the bony fragments that are pushing on the nerves with a little tubular retractor and a microscope, specialized tools, and a very strong light. Finally, if a fracture is so bad that there is just completely shattered bone and total instability, what I do then is I use, again, a tubular retractor, real narrow tube, and I make the incision on the patient's side. Through the side, I can get to the front of the spine without injuring anything serious, anything important. It's a very much bloodless exposure through that plane. And then through that tube, I could clear the fracture and use various kinds of implants, either allograft, which is another person's bone, or these very innovative expansion devices where it's a piece of metal that goes in small, and I turn a screw, a device actually grows and restores normal anatomy. Now look, these operations are more and more rare since these fractures are less and less common. But for those of us who do these operations a lot, even though it may sound complicated, this is sort of where we feel most at home. So if you have a spinal fracture, definitely a word of optimism for you in that most things can be fixed. If you've got questions, we've got answers. And in case you missed it the first couple of times, here's yet another opportunity to see how you can send us questions.
Send in your questions to questions@allhealthtv.com or AllHealthGo on Facebook or YouTube, or visit the Ask the Doc page on our website, allhealthtv.com.
Welcome back. Hiro sent in a question for us. Hiro's question is, hey doc, I went to the batting cages with my son Toshi last week and tweaked my back reaching for a curve. I'm 50 and probably should know better, but I was trying to impress the kid. Anyway, my back is still hurting and I can't tell if it's a muscle strain or a possible spinal fracture. Hiro, it's hard to let go of our youth. I get it. And look, at 50, you should be living your life still pain-free. And when pains occur, you can address them. But either way, if you ask a good question. The pain from what you did could come from a fracture, but it would be very unlikely. There's something called a clay shoveler's fracture, which is an avulsion of the ligament in the back of the spine. But I'll be honest with you, I think I can count on one hand how many times I've seen that. Most of the time, rotational sports like baseball, tennis, golf are associated with disc herniations, as well as pain coming from the facet joints in the back of the spine. It sounds like you're really suffering. I would strongly advise you to obtain an MRI and talk to a doc that can look at the MRI, not just the report, make a proper diagnosis and help you. Chances are it's just a muscle thing. But if you're suffering for more than a couple of weeks, you don't have to keep suffering. Get a diagnosis, and there's so many conservative things you can do. that will make you better. Our next spine-related question is from Kid Dada, who reached out to us from Facebook. Kid Dada asks, Dr. Brusovanik, my father Julius, a legendary hypochondriac, found out that his slightly older brother and my uncle were just diagnosed with a spinal fracture. Now my father wants me to ask you what preventative measures he can take to reduce his risk of spinal fractures. Hi, Kidada, thank you for sharing your story. I think that's a very reasonable question because we are all looking at developing some bone weakening later in life. So my advice is a healthy, active lifestyle. So if you find that you're spending most of your days laying on the couch, if you find that you are your diet is lacking, then of course the advice is to have a balanced diet and to stay active. But after a certain point, even things like activity and a good diet won't supplant the bone. If you're really worried about weakening bone and the possibility of fractures, the real answer is to get a bone density test. That's a simple x-ray. You can then know what your starting point is, monitor it over the time, and if it's weakened, you can jump on the metabolic issue, meaning you can address the decreased bone quality and prevent fractures. And there's great scientific evidence of the effectiveness of that approach. Thank you for that really good question, Kidada. I guess it's an allhealthtv.com website kind of a day. The next question comes to us from Gigi. Gigi asks, Doctor, I'm starting to become a perioperative nurse, and I'd love to get your thoughts on how high-energy spinal fractures, such as those from car accidents, differ in treatment from low-energy fractures. Gigi, that's a really great question. So the differentiation between high-energy and low-energy fractures is a real line. It's a real differentiator. A fall from standing in somebody osteoporotic usually, not always, usually doesn't result in an unstable fracture, meaning that these patients may have pain, but they won't necessarily compress their spinal canal. A high-energy fracture that involves a break of bone or tearing of the ligaments may impart complete loss of stability on the spinal canal. And I can tell you horror stories about individuals who felt their arms, felt their legs, and then tried to get up and became paralyzed. So those spinal precautions after a car accident, they are real. And it's important to abide by those precautions until you can be certain that your spine is stable. Now look, an unstable spine can easily be managed. We have techniques to fix your spine percutaneously. We have techniques to really avoid significant trauma with surgery. But it's important that you know so. So if you were involved in a high-speed accident or a big fall, please listen to the paramedics. Don't try to move or get off the bed until the doc tells you that you are safe. Well, I have just one more question here I really would like to address. The role of physical therapy. AllHealthTV.com, we got a question from Valeria. What is the role of physical therapy in the recovery process? And look, if you find yourself walking in a flexed forward posture after a fracture, that may be a muscular issue, or it may be because the spine has collapsed. Somebody who hasn't walked in a long time and has lost cardiovascular strength, that person can also benefit from physical therapy. Learning how to walk upright and how to get rid of the walker is very important, and therapy definitely helps with that. Now, fractures don't heal by themselves. I mean, fractures don't really get aided by physical therapy. They either heal by themselves or with the help of a spine doc like myself. But Valeria, thank you for this question. And even though physical therapy may be very, very important, I wouldn't just assume that if you have a new onset back pain, especially after a fall, that, oh, I'm just going to go to therapy. My thing is always, you got to have a diagnosis. If you have a new onset pain, or if it's a chronic problem, you got to talk to your doc and make sure that what you think you have is actually what you have, so you can tailor the treatment and get better quick. I thank everybody so much for sending us these questions. Your questions, I'm sure, sounded off in the ears of so many others. So please continue sharing your questions. Don't be shy. There are no such things as bad questions, and I'm happy to address everyone we can.
Send in your questions to questions@allhealthtv.com or AllHealthGo on Facebook or YouTube, or visit the Ask the Doc page on our website, allhealthtv.com.